Good afternoon, everybody, and thank you very much for joining us today for our webinar. This is the third of our COVID-19 series, and I give a warm welcome to Professor Michela Bezzi and Professor Mohsen Davoudi. Before I introduce the topics and also introduce in more detail our key experts for today, could you please all put your microphones on mute, and this will ensure a smooth running of today's webinar. So we've got a great webinar ahead of us, and as you already know, we'll be talking about the multidisciplinary management of COVID-19 affected patients and indications of when to perform a bronchoscopy. So to introduce in more detail, we have Professor Michela Bezzi. She is the Director of Interventional Pulmonology at the University General Hospital, Spedali, Civili of Brescia in Italy. So a very warm welcome to you. Thank you very much.
Thank you.
And we also have Professor Mohsen Davoudi. He is the Chief Pulmonology and Critical Care Medicine in the University of California in Irvine, USA. So a very warm welcome to you both for giving up your valued time, especially in the midst of this COVID pandemic. Thank you. So to give you an overview of today's program, the webinar will run for roughly 1 hour, and we'll have a more in-depth discussion from Professor Davoudi discussing the diagnostic challenges at the moment with COVID-19 and introducing internal protocols which have been implemented. Professor Michela Bezzi will then talk about and share with you a recent SWOT analysis that she's performed in conjunction with local BTS and AABIP guidelines. And then coming back to both to finalize the webinar, we'll be talking about retrospective studies and also prospective trials coming into the follow-up of COVID-19 patients and indications again for bronchoscopy. So of course, we've scheduled some time for some questions and answers at the end. So what I would like to invite you to do during the webinar, anytime you can post your questions in the question box, which you can see on the right-hand side of your screen. And we'll do our very best to answer all of your questions at the end of the webinar. If we run out of time, which in the past we have, but don't worry, we will cover all of these questions retrospectively with both key experts and post these Q&As through our LinkedIn page, our Pentax Medical LinkedIn page. So with that, again, a very warm welcome to you both, and I would now like to hand over to Professor Mohsen Davoudi. Thank you very much.
Thank you. Thanks everyone for participating in this conversation. First, I have to make a correction. I am not the Chief of Pulmonary Critical Care at University of California anymore. I was, but I am from the University of California, Irvine, but I do not hold that position at this point. Just a correction, I think the title was copied off an old document. We will try to speak about what, if any, role bronchoscopy has in the assessment of COVID. And in order for us to basically answer these questions, I think first we have to take a look at where the status of diagnosing COVID stands right now. The three questions that we will come to a little later in the conversation are these three main questions. As I kind of just looked at the topic that was assigned, I thought that there's three main ways we can look at this. One is the diagnosis and triage of COVID, which can sometimes be challenging and not so straightforward. Is there a role for flexible bronchoscopy in the diagnostic paradigm? If so, what is it? Second, we have COVID patients, whether with a firm or not with a firm diagnosis inpatient, and some of them are extremely sick in the hospital. What role does FlexBronch play in the management of these patients? And the third point is that in other instances of flexible bronchoscopy indications, all the other reasons that we do bronchoscopy for, if these happen to be in patients that are either COVID positive or COVID suspicious, what do we do about those? Okay, the slide keeps jumping. Okay, just to start the conversation with a visual effect, because a picture is better than 1,000 words. This is the enemy we are talking about. These images are all either from the NIH or the CDC, so the copyright belongs to both of those federal institutions. This is an electron micrograph of COVID between the dendrites of a dendritic T cell. This is small virion particles inside the cell, in the cytoplasm, between the organelles, replicating. In this part of the image, you can see the protein pieces being assembled, and these are, I guess, the more complete pieces. This is the virions breaking out of the cell and rupturing the membrane. And this is, again, a dendritic T cell covered in SARS-CoV-2 virus particles. Patients that come in with a potential diagnosis of COVID, initially we thought that there was this statement from our Chinese colleagues that was reinforced by the literature, that every patient who comes in with COVID almost comes in with a bad cough and fever. The data subsequently showed that that is not indeed the case always. And there's this like smattering of other manifestations that the disease can have. And as is always the case almost in medicine, not every patient comes with the same picture. So we should have a high index of suspicion when the disease is going around like now, especially if it's an area where there is a known increasing prevalence. And we should look at this schematic diagram that kind of like shows the overlap of all these different symptoms and manifestations. And an open mind basically doesn't guarantee, but gives us a higher odds of making sure we don't miss things. The diagnostic process switches after we have a suspicion to performing the swab. The swab, most of the data that has been collected on the field shows that the false negative rates of the swabs are higher when performed in the field than the specifications given by the companies. And I have seen swabs performed, I've seen them perform very well, and I've seen them perform very poorly. So I think the technique in performing the swab is a very, very big factor in how close we get to the company specifications for each swab and don't use it more poorly than it is meant to show up. This is a review and instruction paper from New England that came out about a month and a half ago. And for those of you, I'm sure most of you have probably seen it by now. For those of you who haven't, please take a look. It's very quick and it comes with a little short video. It's really, really good and educational. There are all these other tests now, laboratory tests for COVID. There's the 2 antibodies, and there's the sites for the extraction of the swabs, whether they're nasopharyngeal, saliva, both, etc. This paper in JAMA that came out about a month or maybe 4 or 5 weeks ago, it basically shows the graph of when we expect to see each of these diagnostic hallmarks appear, and in relation to the patient's possible, if known, contact and the patient's start of symptoms in light of basically the IgG levels, IgM levels, when they go up, when they're expected to come down. Also viral particles in the nasopharynx, in the saliva, and in the stool. Being aware of these kind of ensures that we don't look for the wrong thing at the wrong time and come up with wrong conclusions because we are looking for something that's either overdue or not there yet. Imaging is the strongest diagnostic tool we have after the initial RT-PCR swab. There have been many people who have looked at imaging studies and how they can be used in diagnosing it. Here in Brescia, the two gentlemen who named under that article's name, Doctors Borghesi and Maroldi, Professors Borghesi and Maroldi, they've come up with this wonderful schema that we have used in action here, and many of my colleagues elsewhere in the world, because I speak to friends, have been using it, and it's really effective in both putting the likelihood odds on the first place and following the progress of the patient. And many of you have probably seen this already, but for those of you who haven't, they divide the chest into 6 sections. On each side, the lower ramus of the aortic arch is the transverse line, and the lower line is the inferior margin of the right inferior pulmonary artery. So you draw lines across the chest. That way, each hemithorax is divided into 3 sections, and then you score each of the 6 sections separately. The schema is typed next to there. Score 0 is nothing. 1 is only when you see interstitial infiltrates. 2 is when alveolar infiltrates appear, but there's still a predominance of the interstitial. And then when the alveolar infiltrates become predominant, essentially when you start to see denser infiltrates and consolidation, that becomes a 3. And then you score each section between 0, 1, 2, 3, and obviously 6 times 0 is 0, 6 times 3 is 18, so that's the range. And these are a few images that have been scored, like you see this is 1, 2, 2, 1, 2, 3, so you see an 11 score here, and again, this is a score 14, and this is a score 1. CT scan is obviously higher resolution and higher accuracy in diagnosing COVID. We already know the typical patterns for COVID. It is not very different from many of the other viral interstitial pneumonitis that we have known. So it's not like COVID-19 has a pathognomonic typical CT image, but there are, with the given epidemiological circumstances, with the given clinical picture, and of course timing, where we are in the world right now, there is a very, very suggestive image that you could see that would tell you that you probably have COVID. And there are also schemas that have been created, like the one that I've used as an example here by Professor Colombi and the team in Parma. And they basically look at the density of the aeration versus the parts that are not aerating. And not only do they come up with an odds for diagnosing the disease, but also for giving a prognostication of how well the patient will do, likelihood of mechanical ventilation, and death. This is the study. I will not go into details because I'm kind of running behind on time already a little bit. This is the schema that goes with that last study. The software is available online on this website here. As far as I know, it is proprietary, but I think in certain circumstances it actually is free. I have no connection to the software whatsoever. And these are just some images that have been extracted using that for a patient that basically has an infiltrate here in the posterior left lower lobe. The severity of the disease, of course, could be telling, and the more typical or severe it is, we are more inclined to make a firm diagnostic decision. But patients go through phases, and this was a paper that just came out, I think 4 or 5 days ago. Yes, I believe it was like right at the weekend, Friday or Saturday of this week, in the American Journal of Respiratory Care Medicine, Blue Journal. And as you can see, this is all the same patient. And as the patient progresses from day 6 to 11 to 14, 19, 25, and 29, you can see that there is linear interstitial infiltrates. They turn into ground glass with consolidation, more consolidation, and then they start to evanesce and disappear and be resorbed. The resorption is further advanced here, and there's faint ground glass, and then even that is going away further. So when we see a patient, we could see it in any of these phases. we shouldn't expect a very typical image, like I will not call it COVID unless I see this or this, because we should be cognizant of the fact that we could be seeing a patient in an earlier phase, middle of the disease, or towards the tail end. And because symptoms and the illness of the patient, especially in younger patients, does not always correlate to the badness of their CT image, we could think that, oh, this is an early patient, so we should definitely only see something like this, but the patient's already here because they're younger and they made it through the disease without much bother and illness. This kind of speaks to the last part of my conversation. So I will just show you the images now, and then I will speak about the actual conversation later when we get to the second half of the presentation, after Professor Bezzi speaks. We, during the COVID pandemic, have been, I would even dare say, obsessively focused on COVID, which was good for COVID patients because we read about it, we studied about it, we focused patients, and we tried not to miss or mismanage these patients, neither miss them or mismanage them. But this may have been at the cost of our other patients, and some of these are lung patients, and this was a nice little report with a correspondence in the New England Journal a couple of weeks ago that basically we, or at least these people in a certain area, and I'm sure this applies to all of us, there's no fingers to be pointed anywhere but at ourselves. We have not paid attention to a lot of things. Like this is the San Francisco Bay Area, and as you can see, the curve for acute myocardial infarctions in 2019, which is the beige curve, it goes here, but this year, exactly corresponding to the time when the COVID curve takes off, this curve separates and goes down. And please note that these are not angina pectoris or chest pains. These are actually acute myocardial infarctions with necrosis and troponin. So you can't say the patients aren't coming in because some of the other ones were anxious. These are people who are actually having an MI. So for different reasons, and that's not the place to talk about it now, we are not seeing these patients. So we should be vigilant when it comes to respiratory patients who are our primary patients to make sure this doesn't happen if this comes back or this continues. And we will talk about this in due course shortly. And so this is the message we need to be giving our patients if they're really sick, that please don't stay home. Even if you don't have a COVID, we are ready for you. And a last point before I pass the baton to my good friend Michela is that we used to think that initially we were told by, I'm no microbiologist or transmission or epidemiology expert myself, I'm a clinician. We used to think that we need quote unquote aerosol generating procedures to get droplets. As time goes on and more data is being produced, and this is not a light paper in a light journal. This is by one of the NIH's prime research groups on the field, published in the Proceedings of the National Academy of Sciences. They showed that less than 1 minute of simple speaking, meaning loud, not as loud as even I'm speaking right now, in a closed space, can create aerosols that are airborne. And this is the red one is the curve for the droplets, and the green one is the aerosols. And they stay afloat for a significant amount of time, between 60 and 80 minutes, until they reach the baseline level. And so maybe our distinction between aerosol generating procedures and not, at least for this virus, may have been an arbitrary and not so meaningful one when it comes to doing things for our patients. As long as the patient's in the room and breathing and talking, maybe that is an aerosol generating procedure. With this, I will beg the favor of my partner, Dr. Bezzi, to take over. Thank you.
Thank you, Mohsen. Well, looking especially at the last slides by Professor Davoudi, it really looks like the virus is everywhere, but nonetheless, now maybe a little bit less before when we started with this clinical presentation of the syndrome. and the CT scan was, full of consolidations and very, predictive of COVID-19 infection. But nonetheless, sometimes the swab can be negative. Of course, it depends on how you can perform the swab. We've seen by Professor Davoudi how we should do that. We can go through the nose or through the mouth. Sometimes we pick some saliva, and depending on where you perform the swab and who is performing the swab and what day of the disease we are picking the swab, we might have different percentages of sensitivity in this RT-PCR test. And it can be very different, especially our patients didn't come in the hospital at the same time. Some patients were still almost asymptomatic when they came in, so at the very first days only with fever. Some other patients came very late because, as you know, maybe as you probably know, we've had many patients referring to our hospitals. We've been hospitalizing almost 1,200 patients in the central weeks of March in our hospital, which is a 2,000 bed hospital. So in some cases we were like obliged to make these patients wait at home in case they were not too severe. And when they were referred to the hospital, they might stay a few days at the emergency department before coming to the wards we had dedicated to the illness. So sometimes patients came in after 1 week or 10 days, and the swab could be negative. In the beginning of March, it was really rare, like 90%, 95% of our swabs were positive, because also of the high prevalence of the disease in the city, in the area. But in the last few weeks, negative swabs became more and more common. So that's why in many cases, we as interventional pulmonologists were asked to perform a bronchoscopy and a BAL to look for COVID-19, for the virus in the bronchoalveolar lavage fluid or the aspiration fluid. We've been discussing a lot about when we should do a bronchoscopy in these patients and why we should do that. And we've come in the last few weeks to this SWOT analysis I'm sharing with you. Of course, the bronchoscopy as an invasive procedure has some drawbacks. It generates airborne aerosols, which is possible a cause of contamination, of infection. And it has to be performed, it should be performed in a negative pressure chamber, which was almost never the case because we tended to do these bronchoscopies in the patient's room, and possibly he was isolated from other patients. Sometimes we had double rooms with 2 positive patients and we were performing bronchoscopies in the patient's chamber. And of course, organizing all of these procedures, and I mean the logistic and the cost and the difficulties which were linked to this high number of bronchoscopies performed in these patients was not very smooth actually. And the sensitivity of the bronchoscopy is also as high as the one of the CT scan, as we've seen by Professor Davoudi in the last slides. So these are the weaknesses why we shouldn't do a bronchoscopy in these patients. There are also some threats which are pointed out here. First of all, the possible exposure of doctors and nurses to the virus. And if you consider that these nurses and these doctors need to be skilled in doing this procedure, you can understand that even in a big hospital like the one we have, even where you have an interventional pulmonary department, you will almost have the same 2-3 persons performing the bronchoscopies in these patients. That means if we've done around 300 bronchoscopies in 2 months, that means at least each of us has done 100 bronchoscopies. And as Professor Davoudi said when he came here some weeks ago, speaking to Federico, one of our colleagues, he said, you are probably the doctor in the world who has done the highest number of bronchoscopies in COVID patients. And colleagues kept asking us for a validation, a verification of the infection. And of course, using all of the protections we had, we tended to do these exams, and we are now asking ourselves if it's really necessary to do so. We've been using mostly single-use scope, not really because this is an infection which is difficult to eliminate from the scopes, but because we moved to any part of the hospital doing these examinations and procedures, and we didn't have to take the bronchoscope back to the OR and to expose other nurses or technical personnel to the decontamination of the scope. So the best was go into the patient room, do the bronchoscopy there with a single-use scope, and then throw this away and stop any possibility of contamination, taking the scope around in the hospital or giving it to another nurse who was supposed to decontaminate it. BAL is, of course, the procedure we did. We could be looking for some special part of the lung where the consolidations were more present. In some cases, aspirations of the secretions from the trachea or the bronchi was enough. Both these techniques expose the patient in severe condition to a possible risk. So these are the main drawbacks with performing a bronchoscopy in these COVID-19 patients. But of course, it does have some strengths and opportunities. It offers some opportunities. First of all, because bronchoscopy in the patient with a suspicion of COVID-19 infection has a very high diagnostic sensitivity, 93% versus 63% of the swab RT-PCR procedure. And also, performing bronchoscopies in the patient with a suspicion of COVID-19 could optimize the therapy. And this is the very important point, probably. We should always do a bronchoscopy when it can give a chance to the patient to have a different therapy, a different treatment, a different indication, let's say for intubation or any kind of different treatment modality, which makes us actually perform the procedure, even if it's sometimes a little bit risky for contamination for the nurses and for the doctors who are performing that, and also for the patient. So this SWOT analysis is very similar to what happened in the rest of the world where the COVID-19 spread. This paper in respirology is summarizing some societal guidelines regarding the use of bronchoscopy during the COVID-19 era. And the topics it refers to, it might be a little bit different if we are speaking about a patient who has a suspicion of COVID-19 infection, or in which the infection is confirmed, or if we are speaking about a patient who's referred for other reasons to our bronchoscopy room, but he's coming from a region with a high prevalence of COVID-19 infection, and in a hospital where you have a lot of patients with this infection. So it can be a little bit different depending on the indication of the bronchoscopy, but the timing of the procedure is always really important. And all these aspects we've been referring to, like the PPE, wearing a mask, which eye protection, and how to approach the patient, what the patient should be wearing. As you can see in this paper, I suggest you to read if you haven't done so yet, are really important and very similar to what I've been discussing till now in the SWOT analysis I showed. These are some more recommendations. In UK was hit with the pandemic as well, and they probably had a little bit different attitude if the patients were referred to the hospital for an indication concerning lung cancer. In our institution, we probably did the same. And if the patient were referred for any reason which was not a suspicion of lung cancer, we tended to postpone the procedure to a better week, probably when the COVID-19 infection had left, hopefully very soon. But if malignancy was suspected, then we tended to exclude COVID-19 active infection and to perform the bronchoscopy anyway. So we've been doing EVOS and fluoroscopy and rigid bronchoscopies during the pandemic. Maybe the numbers were a little bit lower than before, but we did many procedures with this indication. The most interesting part is probably this update of the AABIP guidelines about when and how to perform a bronchoscopy in the pandemic era of COVID-19. The first recommendation, we have actually 6 recommendations from this paper, which is also really interesting. And actually, we only read this paper when we came out, but we had been talking about the same topics and sharing the same views, even if we are like 2,000 kilometers away from the people who wrote it, because our situations were really similar. First of all, what we've been saying for weeks and weeks is protect yourself as a doctor and protect yourself as a nurse, whatever you are doing. You can be doing a bronchoscopy, you can be just looking after the patient, giving therapy, or talking to the patient. The first is protect yourself. So any kind of PPE like FFP3 masks for bronchoscopies are really important. Otherwise, it's probably better not to perform the bronchoscopy if you cannot protect yourself and the nurses and whoever is involved in the procedure. And of course, if a patient is suspected of having COVID-19 infection, first of all, a nasopharyngeal swab should be obtained to ascertain this infection. And in case the swab is negative and the illness, the syndrome is clinically or radiologically suspected, then you can perform the bronchoscopy only in the case where it can change the patient therapy or outcome. Not only for patients in whom the infection is suspected, but also when an asymptomatic patient presents for bronchoscopy in an area like our area in these months where COVID-19 is present, we should always wear proper protection like an N95 or an FFP3 mask. And not only this, but also whenever an asymptomatic patient, asymptomatic referring to the COVID infection, is coming with any indication for bronchoscopy, we should always be testing this patient prior to the bronchoscopy for COVID-19. This is what's happening also now in our hospital. COVID-19 has almost disappeared in the last few weeks, but we are still testing every single patient who comes to the hospital for any indication for hospitalization, any kind of surgery, or even, of course, for bronchoscopies. We first test the patient before hospital admittance in the 24 to 48 hours before hospital admittance with a swab to make sure he's not infected with the virus. And as we said before, if the indication is cancer, in some cases the bronchoscopy should be performed anyway. But if the indication is not cancer and the bronchoscopy or any kind of surgery can be postponed, we think that it's a good practice to put it off to the solution of the infection at least 2 weeks after the diagnosis and treatment, and possibly after 2 negative swabs. So when bronchoscopy is indicated, when we want to diagnose or to stage lung cancer, first of all, we perform the swab and we make sure the COVID-19 infection is not there. And then, depending on where you work, in which hospital, how many bronchoscopy suits you have, you should make sure that this patient is properly protected by any cross-infection by other patients, even by the nurses or by the doctors themselves. And it depends, of course, on where you work and what facilities you have available, but that should always be your first intent, to protect cross-infection. And last but not least, in patients with a confirmed COVID-19 infection who recover from the disease and comes to our bronchoscopy unit for any indication for bronchoscopy, again, we have to make sure that the severity of the disease, of the COVID-19 syndrome, is gone, and that the virus is not there anymore, and then decide the right timing for the bronchoscopy depending on resolution of symptoms due to the infection. And that's what's happening now. We are seeing many patients who were hospitalized for COVID-19 severe acute respiratory syndrome, and well, luckily they could recover and go back home, and they stayed at home in this forced isolation for 2 weeks, and then they come up after 1 month or 3 months for a follow-up visit. They have a chest X-ray or a CT scan, and we still see some consolidations on the CT scan or the chest X-ray images. And in some cases, especially if the patient is still symptomatic with dyspnea or desaturation when he tries to walk or make any effort, in some cases a bronchoscopy might be useful, like we are doing actually these days. And going back to what we have been doing to the indications for bronchoscopy in patients with suspected or confirmed COVID-19 infection in the last couple of months, this was our flow chart, which depended very strictly from the CT pattern. So first swab had to be, of course, negative. If it was positive, the patient would start treatment. And then we asked our colleagues to have a second swab in case of the first swab was negative. And if the second swab was positive, of course, patient would go for treatment. And if the second swab was negative and the CT scan showed a pattern which was very likely to be due to the COVID-19 infection, then we would perform a bronchoscopy with a BAL or with aspiration of the secretions from the trachea or bronchi to make sure the COVID-19 infection was there. We are now looking back at our data from the bronchoscopies we performed, and we don't have any precise analysis of this data yet. The paper hopefully will come out in the next few weeks or months. But what we know is that almost 95% of our BAL were positive for COVID-19 infection, even in those patients in whom the second swab was negative. So in case you really need to make sure the patient is infected with COVID-19 and you have 2 negative swabs, it might be useful to perform a bronchoscopy, which sensitivity is actually higher than the swab. I think I should pass the slides to Professor Davoudi again.
Hello again. That was really nice summary and putting it together by Michela. Wonderful. So the three questions we asked up front, I'm just going to very briefly go through them, and based on what we discussed and what we can put together from what we said and I said and what Michela said, we can come up with, try to come up with answers for these. Is the diagnosis or triage patient sometimes helped by flexible bronchoscopy, and how can we use this in the diagnostic paradigm? As always, we need to look at the cost benefit. There is definitely a cost in all the different ways that Michela showed in her SWOT analysis for this, both cost in terms of resources in dollars and cents, in terms of possibly putting many of the staff in the line of exposure to harm, and also even possibility of hurting some of these patients themselves. So there should be a cost benefit analysis. In order to weigh on which side this basically, which side of the scale becomes heavier, we should look at the sensitivity of the lavage. Reports show that in a positive patient, the lavage and tracheal aspirates are approximately 90 to 93% positive. That's good sensitivity. On the one end, if you compare it to the swab, which is around 60, 65, 70 different swabs, different companies, different RT-PCR processes, well, that's a significant difference between 60 to 90 or 65 to 90. That is a very significant proportion of our patients that we may be leaving in limbo and putting in the intermediate, undiagnosed, and just under suspicion category. On the other end, CT reports, good ones that have been done, show that CT has a sensitivity of around 88 to 89, 90. So maybe a hair or two or three less than the bronchoscopy, not by miles and miles worse. So if we indeed have two negative swabs and an unsuggestive CT, not an intermediate CT, unsuggestive CT, perhaps we should relatively confidently call that negative and not proceed to a bronchoscopy. The problem arises when the CT falls in the intermediate range and the swab is negative, but your clinical inclination is that I wonder whether this patient really has COVID-19 or not. Those are probably the cases that merit a good discussion with the patient, with the team, and if the decision is made to proceed. And those are the patients that in this unit were the ones that were mostly chosen and done. And as Michela quoted me, some of the good colleagues and partners here, herself actually, she's kind of not self-congratulatory, but she herself and the other two partners that she has, Dr. Mauro Novali and Federico Quadri, they are probably some of the people who've done the most flexible bronchoscopies anywhere for COVID. So these were the patients that were chosen based on the kind of process we just went through. The issue of pretest probability is kind of important here. If you are in an area like we were in Lombardia for several weeks and 2-3 months, or some places that are unfortunately going towards the surge of the disease right now, and clinical pointers are more or less suggestive of COVID, probably a negative bronchoscopy will not rule that patient out for you. As you know, the negative predictive value when you have a very high prevalence is much smaller based on a false negative. So in those cases, I really doubt that a bronchoscopy would be a judicious choice. Whereas in some countries that COVID did go, but it didn't go to the point that it would be considered like of vast epidemic proportions. And I don't want to name places, but there were quite a few places in the world that did have that condition. In those places, if you do have a clinical suspicion of COVID, if you add the extra added weight of a negative bronchoscopy result to it, you're probably confident enough and within your reasonable domain to rule that patient out and basically isolate them for 2 weeks and let them be, rather than putting them on a COVID ward and treating them like an active patient. The second question we initially had was, what other roles does bronchoscopy play in the management of these patients? This is COVID patients. Well, first of all, a lot of these people end up in the ICU or in the step-down units, one notch below the ICU. Well, there's a lot of things that a flexible bronchoscope and a flexible bronchoscopy does that are integral components of good ICU care. Whenever we need alveolar or airway sampling for these patients, if there's suspicion that there's bacterial superinfection, any other cause for sepsis. As you know, because of these patients being severely lymphopenic, many of them are almost like bad AIDS patients, and they could be prone to many of the opportunistic infections. And if you need to make a diagnosis to treat that, well, the bronchoscope is one we use in other ICU. So whether it's for microbiology, cytology, some measurement of cytokine, different yay or nay vote for a rising wave of a cytokine storm. The data isn't completely out on that yet, but the question has been posed. In these cases, then the bronchoscope is a tool that gives you access to the alveolar space. The other one, again, an obvious case, is secretion clearance. If you have a patient who's severely mucus plugs, and conservative measures, as we all know, do not resolve that issue, well, you can't let a patient have a 2 or 3 lobe atelectasis and die because of a mucus plug. You have to go in and clear it out, or bleeding occasionally. And also, as you know, in the ICU, sometimes the ventilator pressures and whatnot, they're just doing all sorts of funny things, and you wonder whether the ET tube is clogged or something else is happening. You just need to go and take a look, check where the ET tube is positioned, whether it's torted or not, whether there's a coagulum inside it. Again, it's a very easy procedure, and with good protection, you can do it. And also, some of these patients who are not originally intubated are in the step down, and then they end up decompensating. Not for every patient and not for every operator, but for an operator who considers himself not only a bronchoscopist, but a strong bronchoscopic airway management doctor. If you basically do an induced apnea bronchoscopic intubation for these patients, you could have a very, very low aerosol generating endotracheal intubation. Essentially, you make the patient apneic, you cover the face with the mask, and then you go through the orifice in the mask and intubate in like 10, 15 seconds. Very safe, very few staff in the room, and effective and safe for the patient as well. And the last question, in what other instances are flexible bronchoscopic procedures in active COVID-19 patients that are not related to their COVID? These are the ones that Michela was talking about towards the tail end of her conversation, cancer patients. And it's not just cancer. If you have a young 26-year-old girl who has bad Wegener's and she's known to you, and she calls you, or you see her, or you see the x-ray, and it seems like, oh, gee whiz, she's closing off 2 lobes again with Wegener bridges. Well, you don't want to let this young lady lose 2 lobes because you're worried about COVID. This may not be cancer, but it could be worse than cancer in her life outcome. And though we have a very bad recurrent tracheal stenosis, the patient's basically decompensating. And I could go on different indications. I tried to list indications for this, and it seemed kind of like a fishing expedition, just like reaching in my mind and finding all sorts of stories. And all of you are competent and smart clinicians, and you don't need me to tell you the examples when you really need to go and help your patient with a bronchoscope. So I'm the guest of the descendants of Romans, saying that I learned in my college classics, prudentia et judicum vincet, which means prudence and good judgment always prevail. So if you act what you do based on a good cost-benefit analysis and a thought process that is justifiable and plausible, you can reasonably you can reasonably discuss it and give a favorable pro-con set of columns for it, I think that is justification enough if it's not done with any prior biases. And thank you again, and I will pass it on to, I believe, Dr. Bezzi, or is it Ms. Dalton? I don't know.
Yeah, there's actually only very few more words to add to what we've been discussing till now. And the last slides are about the follow-up to our patients. And again, we've been meeting all of our colleagues from other specialties in the last weeks, discussing what is the actual follow-up these patients need, and do they need any bronchoscopy in the follow-up. Of course, all of us agree, like the British Thoracic Society guidance tells us, that these patients need a follow-up, of course, especially the ones who were in the ICU and intubated, but also the patients who just had this dramatic disease, even if they didn't need any intubation. And we normally see these patients 1 month after discharge with a chest X-ray, and pulmonary function tests might be very useful, but they need to be performed in a proper way in order, again, to avoid cross-infection. And blood tests can be very useful. Actually, in this flow chart, depending on what actually is still there after the patient recovery, we might need a CT scan, and bronchoscopy might come up only after the CT scan, in case we have some abnormalities on the CT scan 3 months after discharge. Of course, what we expect to be there is not the inflammation anymore. It's probably a consequence of the infection and inflammation of the immune response to the infection. And pulmonary fibrosis is the most likely consequence to this dramatic severe acute respiratory infection, which is caused by the COVID-19 infection. As we've seen with previous virus infection like the MERS and SARS 10 and 20 years ago, almost 30% of patients might develop a chronic respiratory insufficiency due to the fibrosis, which can develop after the inflammation. And that's what we are actually looking for in these patients. But what is new now compared to 10 years ago and 20 years ago is that perhaps we are not just there to diagnose this pulmonary fibrosis, but we might have some weapons we didn't have before, some drugs we can use in these patients in order to prevent the development of this fibrosis, and also to maybe make this condition better using these drugs. So Professor Mohsen and I, in the last few weeks, have been proposing a protocol to our ethics, and hopefully this study is going to start very soon. And we proposed a CT follow-up with a cryobiopsy, transbronchial cryobiopsy in these patients. You know, this procedure is not routinely performed in every interventional pulmonology department, but it's a safe procedure if you perform it in the right way, in rigid bronchoscopy, with proper intubation and general anesthesia, in a setting where both the IPs and the nurses and the anesthesiologists can manage any kind of complication like bleeding or pneumothorax. And we think that getting the histology from this condition might be really important. We do have a lot of data from autoptic studies and they are quite consistent, showing that we have this ischemia which can lead to the fibrosis. So the idea is to follow up these patients as we discussed before, with a chest X-ray and CT scan and pulmonary function test. And in case they are not back to normal, back to baseline, we can continue in step 2, 3, and 4 with more invasive procedures. After lung function, we might consider performing a flexible bronchoscopy with a BAL. I didn't have enough time to upload the pictures from the bronchoscopy this morning. What I saw in this patient who came for these reasons is like a stricture of the left upper lobe and its segmental bronchi due to like a web membrane, not really an inflammatory response, but what could be there after the inflammatory response. And when I went back and looked at the CT scan and chest X-ray of these patients who were hospitalized from the beginning of March until the half April, actually the most affected lobe in his chest X-ray and CT scan was the left upper. So there might be a need for performing bronchoscopies to make sure these patients don't have bronchial strictures, but then in our protocol, we consider performing the transbronchial cryobiopsy in order to get enough information to give this patient the proper treatment, pharmacological treatment, in case that's needed. And what we think is really important is to share this information. I can change the slide, doesn't matter, with other colleagues. You know, there are, yeah, this is the last one. Oh, sorry. Okay. So apart from discussing the results and the histological results and the radiological images and the endoscopic images with our colleagues in our hospital, it might be very interesting to share these data and these conditions with other multidisciplinary team which are really expert in pulmonary fibrosis and the use of these drugs for interstitial lung disease. In the rest of Italy, we have a number of centers which are really skilled. So our proposal is to have this patient perform the bronchoscopy, do the transbronchial cryobiopsy, and discuss any data from these procedures with our colleagues in the hospital and from other teams in Italy.
So thank you both very much for your valued input and extensive knowledge. And actually, at the moment, we've just reached the end of our webinar. So I would like to ask you both, do you have a spare 5 or 10 minutes to answer a few questions which have come in from the participants? Or do you need to get back to your surgery?
I actually have a meeting in the hospital administration, but I have 5 more minutes.
Okay, then maybe we just have time for one more question then, if that's okay. So the first question is, did you see an increase in bronchoscopy during the COVID-19 time compared to normal? And if so, what was the main reason, do you think?
Well, we didn't really have an increase in the number of bronchoscopies because we normally perform about 3,000 bronchoscopies a year. And that means about 15 to 20 bronchoscopies a day from Monday to Friday. But what has dramatically changed was the indication for these bronchoscopies, because we tended to postpone any indication which was not cancer. So we were doing EBOS and any kind of procedure in suspicion of lung cancer or other tumors. But the rest of the bronchoscopies were a number of BAL performed for the diagnosis of COVID-19 infection.
Okay, thank you very much. And maybe just one short question. There was a question whether you both anticipate or expect a second wave of COVID-19.
Nostradamus, we need that. Well, I don't know what Mohsen thinks, but I think that the virus now has really disappeared in our region, and it's summertime. The weather is not today, but normally the weather is good. Nobody is coughing or squeezing, or I mean, there are no other virus infection. So in these months, probably June, July, and August, and probably also September, we do not expect to have an increase of a number of people coming up in the hospital with fever or cough or any, hopefully, radiological infiltrates. What we really expect to happen is a second wave in October, November, which could be due to any other virus, any other flu or whatever other virus. It could be similar, relative, a cousin, as we say, of this coronavirus. I mean, children say, don't go for COVID-19 because COVID-19 is coming in September. So by the other one, they speak about the virus as it was an iPhone. And yeah, we expect a new virus in October or November. We do not expect it to be as severe as this one. If we go back at history and we look back at what has happened with the SARS and MERS infection and endemics, there were about 10 years between one virus and the other, and hopefully it's gonna be like that. We cannot tell that, but what is really sure is that next time in October or November, whatever, we will be ready to face the epidemics, probably in a different way compared to what we did when it was not expected, like with more active doctors at home, or with more ICU beds, and I mean more doctors dedicated to these patients, as happened before when we had to stop almost every activity in our hospital, and all of the doctors and the beds and the nurses were 100% dedicated for about 8 to 10 weeks to the pandemics.
Okay, thank you very much for your interesting answers to the questions. And given the time and also your other commitments, I would just like to thank you both very much for your time and your pulmonology expertise, and also sharing your knowledge and experience with other clinicians and healthcare workers in the industry so they can gain from your knowledge and experience. And just to communicate our future webinar plan, we have 2 more webinars coming up, one scheduled in 2 weeks on the 18th of June, where we have 2 key experts from Germany talking about COVID insights and challenges in daily GI endoscopy. And then on the 8th of July, we will focus on more reprocessing and infection control guidelines, and whether COVID-19 will actually improve, or let's say change the focus more on the importance of hygiene and infection control. So again, I thank you both very, very much for your time and valued input. We appreciate that very much, and I'm absolutely confident that the input from today really supported the community globally. So thank you very much, and we wish you a nice afternoon.
You too. Thank you. Bye.
Thank you very much for joining, everybody. See you at the next webinar. Bye-bye. Thank you.